Hello again, everyone. Again, my name is Jeanne Chirico, and today I have the honor, really an honor, to be here to talk about our community-based pediatric palliative care program, and I would be remiss if I didn't thank Dr. Pat Bomba for helping to encourage getting me here. So CompassionNET, as I mentioned, a community-based program that resides in upstate New York. So this pretty little graphic gives you the territory that we cover. And this program is a sponsored program of our BlueCross BlueShield Excellus, which covers upstate New York. And so one of the few things I wanted to mention before we dig into the details of this program were, as you can see from this territory, this is about 300 miles of territory. Covers both rural and urban, the most urban area being Buffalo, New York, and then Rochester, New York, and Syracuse, New York. Yes, the great Syracuse University. But in between there are some very, very, very impoverished counties, rural counties, difficult to get to counties. And then, so we border on some of our families take ferries from upstate, the North Country, over to Vermont, and other families might travel from the Buffalo corridor over to Philadelphia to the Children's Hospital of Philadelphia there. So very large geographic context. And I'd like to paint a little picture for you. I'm not going to talk about all the details of our program because I'm here to talk to you about money. But I think what you'll see are a lot of similarities. We're talking about kids, but as we discussed earlier this morning, what we're really talking about is the family as a unit, whoever family is for that individual. And so this program is a wraparound program that supports the entire family as a unit and provides for all their needs, whether they be psychosocial, financial, medical, environmental. So this is a program that is available to any member from birth to 21 years of age. And over the last few years, we incorporated a high-risk perinatal program. And as long as the child is at risk to die before they reach adulthood, and we use the context of 21 years of age for adulthood following what the developmental disabilities programs. So the child could have a new onset, or this could be an acute exacerbation of an illness. The primary goal of the program is to provide qualified staff, education, and emotional support to families, and allow for a realistic option for their child to die at home should that become necessary. So let me say from the outset that not all the kids enrolled in this program succumb to their illness. There's about a 30% of our kids who go into remission or are cured, and another 30% who do die on our program, and then we keep kids on for longer than a year, so they roll over from year to year, okay? And before I get into the details, I do need to give you a context. So, as a provider of home care and hospice services, back in 1999, yes, I've been around that long. I know I look too young for that, but we were informed by families that we really were not doing a very good job of supporting them when their children were succumbing to an illness. Their children were dying in the hospital because they did not feel safe at home with our care. That was very difficult to hear, but we needed to hear it. And it just so happened that concurrently, the health insurance company that actually owns us was not doing a very good job either. And families were receiving denial letters in the mail for things that their child really needed. The children weren't eligible for wigs like adults. It was taking 3 hospitalizations for a trigger to hit case management services. And so we boldly let the insurance company know that they too needed to change. But to their credit, and this has gone on since the inception of this program in 2001, they've stood by this program and said, do what we need to do to make this right, and we will live with the right action, and there hasn't been a question of the cost. Now, you might say, wow, that's a fairy tale. That's never going to happen where I am. But what I want to say is they didn't have to worry about that cost because we, as stewards of this money, act as if this is the greatest gift in the world and we're not going to abuse it. And so what we did was create a program that doesn't replicate any service that's already available in the community. It doesn't pay for anything that's not a need. It is not a want program. It is a need program. And we built collaborations with hundreds and hundreds of community-based organizations. We built a network, and that network is accessible to any one of our family members. And so what happens is the assessment is done on a family by a social worker, a licensed social worker who does a needs assessment with the family and the child to determine what are their biggest stressors, what's keeping them up at night, what are they most afraid of is going to happen. And then they can put in services to meet those needs. That can include anything from expressive therapies, not just for the child who's ill, but for the siblings who don't understand what's going on. That can include massage therapy, not just for the child who's ill, but maybe for the mother who is caregiving nonstop. It can include things like assistance with finances. So what that means is the family is putting all their money towards their medical bills and they're going to get their heat shut off. So our case managers go to the community resources, find the money to help them with that, and then put a plan into place to assure that doesn't happen again. But it could be the child or family has to go from our area to Boston for special treatment because these children's illnesses can be so rare they have to go out of area. And so to go to Boston, I don't know if anybody's from that area, just a one-night stay in a hotel can be like at least $300. And there is a Ronald McDonald House, but how many beds do they have considering the size of that hospital? So what we do is we put parameters about what we can help with, what we can't. And you're going to be amazed, the price is not exorbitant because everybody contributes. Nobody is making this a wish list. The primary goal of our program was to design something where people felt they could have their child die at home if that's what they wanted. That requires education, support, 24/7 pediatric palliative care expertise that is available not to replace the home care, not to replace the hospice, but to be there for their backup because they get nervous. They're not sure what to do. They don't have children dying on their programs all the time, but we are there. We can go out to the home and support them. We can help them with medication suggestions, etc. And we have bent the curve on where children die at home, where they die. So statistics from NHPCO, as you can see, from 99 and to 2013, for children ages 1 through 9, that middle column there, NHPCO statistics of 99 show that less than 20% of kids died at home. In 2013, that only just barely made it above 20%. But for our program, kids ages 1 through 9 die greater than 50% of the time at home. And this is usually preference-based. So the family might feel more comfortable going to the hospital. They don't want their other kids home when that's happening. So this is an important thing, one, because this is quality. Studies have shown that when families can make that decision about where they want this event to occur, their bereavement is better, their health is better. Okay. So, maybe I'm done with that. Well, there was another slide that was going to show you the most recent good news, which is that we did We were able to get all the claims data for all the kids that died between 2008 and 2015 and do a cost analysis, a cost savings using the Excellus BlueCross BlueShield claims data and our program data. Well, there it is. A busy slide, but it's in your handout that you have, and I'm giving you this information that we hope to publish in the Journal of Palliative Care. But what it's telling you is that helping families get the support that they need to feel safe at home and have their child die at home also is enough savings, cost of care savings, to pay for the entire program for all the kids. Okay, so there is not an increased expense here. This is a shift of expense, and that shift improves outcomes, improves quality of care, improves bereavement support, improves the health and well-being of the siblings, let alone the parents. So it can be done. And so when I talk about community-based organizations, I just want to say that there is a method and a systematic way to bring communities together in a fashion that you can make these things happen.